I guess we're going to move on to the official meeting. And given with all the faces here, I mean, there's quite a few of you, and I will call the roll because think I've got everybody down. But I would like anybody who is new to this group and an advanced and is here for advice with advanced cancer, prostate cancer, to please put your name in the chat window so I can identify you and we can talk to you first. So if you could do that, that would be great. And given while we do that, why don't I, and I'm going to call the roll alphabetically. Oh yeah, the chat window is, thanks. The chat window is that little box on the upper right-hand corner, which looks like a balloon. And if you click on it, it will open the chat window. And I'm going to call the roll alphabetically this evening. I'm really out of touch, just because it will help me move along a little more rapidly. So let's start. Alan Moskowitz. Alan, do you have anything tonight? Would you like to update us tonight?
No, I don't need any time. Thank you.
Okay. Ben, do you need any time? No. Okay. Cal, would you like some time tonight?
No, I don't think so. I'm just kind of suffering through my first week of chemo.
Okay.
Trying to stick it out, but otherwise I'm just observing tonight. Thanks.
Okay. Carl, would you like some time tonight?
I do not. Thank you.
Okay. Carlos, would you like some time tonight? I know you're there. Is that a yes or a no? No. Okay. Fine. Okay. Chuck Lindsay, are you new to this group?
Yes, I am. Yep. Yes, I would like just a little bit of time just to ask about about radiation oncology.
Right.
You're new.
Hold on, Chick.
Yeah.
Weren't you with us last week? Weren't you new last week and we talked to you?
Yes. Yep. Yes,
right.
Okay.
Yeah.
So you would like some time tonight. Okay.
But he'd like some time. Thanks.
David Muslin, would you like some time tonight?
No, thank you. I'm good tonight.
Okay. And I know Dennis McGuire, would you like some time tonight?
Not tonight, thanks.
Okay. Frank, I have you down. We're definitely going to get to you. Gary Peters, would you like some time tonight?
No, thanks, Herb.
Okay. George, would you like some time tonight? George,
Herb, no, thank you. But thank you for moderating, and thank you for your fine presentation, and thanks to all the presenters.
You're all welcome. Jim Barnes, would you like some time tonight?
No, thank you, Herb.
Okay. Jeff Markey, would you like some time tonight?
No, Herb, thank you.
Okay. Jeff Wood, would you like some time tonight?
No, thank you, Herb.
Okay. Jerry Pelford. Jerry,
Herb, I think you missed Gregg, and I'm not sure if Gregg is new or not.
I was going to ask if Gregg was new. I didn't miss him. He's on my questionnaire to be asked if he's new.
This is Gregg. I'm not new, and I don't need time.
Okay.
Thank you.
Okay.
All right. This is Jerry, and I do not need any time tonight. Thank you, Herb.
Okay. Jim Marshall, would you like some time tonight?
Negative.
Okay. Jim Ward, would you like some time tonight? Jim, are you there? We'll come back. Jimmy, would you like some time tonight?
You've heard enough from me tonight.
Well, we'll never have enough from you. What are you?
Well, I'll comment on someone else then.
Okay.
Herb, you can cross Jim Ward off. He had to take off.
Joe Gallo, would you like some time tonight?
I'm fine, thanks.
Okay. John A. Dr. John, would you like some time tonight?
No, thank you.
John Birch, would you like some time tonight?
I'm good, thank you.
John Ivory, would you like some time tonight?
No, thanks, sir.
Oh boy, nobody wants time. John McPhee, would you like
No,
some
thank
time?
you, Herb.
Everybody knows who's coming next. Julian Morales, would you like some time?
No, thank you.
Okay. Ken, would you like some time tonight?
I guess if no one's going to chat, I can give an update.
Good. Okay. Yes, we need somebody to give an update. Larry, would you like some time tonight?
Not tonight, thank you, Herb.
Len, would you like some time tonight?
No, thanks, Herb, but we're hearing a clicking sound, which we think is coming from, do you have any idea what might be causing it?
From me?
Yeah.
Oh.
No, I think I figured it out. I think I figured it out, and I think I've taken care of it. If it keeps clicking, we'll ask again.
Okay.
Okay. Got it. Okay. Mark, Dr. Mark, would you like some time tonight?
No, I'm fine, thank you. I think there are some people who are not muted in the chat window, so if they're not one of the presenters, maybe muting will stop the clicking.
Right. Michael Weiss, would you like some time tonight? No answer. We'll come back. Mike Phillips, would you like some time tonight?
No, I don't need any time tonight, thank you.
Okay.
The clicking is definitely coming from you.
It's coming from me.
Yes.
All right. Well, I'll switch mics.
It's not the worst. It's just there.
All right. I mean, I've had trouble since I upgraded this. Can you hear me now?
Yes.
Much better.
And Herb, I think it was Michael Chandler that you were called on, not Michael Weiss. Michael Chandler, do you need time tonight?
No, I don't, not any time. Thank you, gentlemen.
Okay, sorry, Michael. Michael, okay. Pat Martin, do you need any time tonight?
I'm good, thanks.
Rita, do you need any time? No, I'll come back. Peter Monaco, would you like some time tonight?
No, Herb, I'm good.
Okay. Bob McAleese, would you like some time tonight?
Yeah, I'd do an update. Thank you.
Okay. Russ Hoover, would you like some time tonight?
No, thanks, Herb. Thank you.
Okay. Dan Friedman, would you like some time tonight?
I'm okay, Herb. Thanks very much.
Steve Saft, are you going to want to update us a little bit?
I guess if it's early enough, I'm probably going to run out of gas in about an hour, but.
Well, we can put you up at the beginning so we're going to run out of gas.
Hello?
Okay. Ted Healy, would you like some time tonight?
No, thank you, Herb. I'm fine. Thank you.
Okay. Now, please, have I missed anybody just because it's a large crowd?
Yeah, you've got two more people coming up, Tom Seigel and Vic.
Tom? And
Seigel? Hi, I'm new to this group. I've been on with other groups. I was particularly drawn to the subject of hormone resistance. And I'd like to digest it in safe time and not give a comment this time. I'd like to save my comment.
Okay. And Vic, are you new to this group?
No.
And would you like some time tonight?
Yeah, just a brief period. You can put me near the end. Thank you.
Okay. Okay.
Okay, now let me just say, Tom Seigel, I know that you're frequently on the low and intermediate group. If you would like to comment at all in this group, you're more than welcome. Just a heads up that you may hear stuff in this group that you may not want to hear. So I'm just giving you a heads up about this group. So.
I appreciate that. If there's time, I'll make a comment, but I'll hold for the others, the regulars.
Oh, okay. And I have a question. Herb, would you like some time tonight?
I guess I would.
I thought so. So I think Herb, I think Herb, you should put yourself fairly near the top, maybe right after Steve Saft, because I think you have some priority here, and I think you deserve the time.
All right, I will do that, and I'll let you I'll let you take over when I'm updating. Anyhow.
Okay. All right.
So David, welcome to our group. And the way we'd like to introduce you to the group is I'm going to ask you some questions about you and your disease, which help us get oriented. And then on the basis of that, we'll go to the question is, how can we help you based on where you are? So here, I guess the first question I have, David, is how old are you? David, are you there? Is David
His
here?
mic is off. Yeah, Dave G.
David Goley?
Yeah, Dave G. Are you with us?
Here I am.
Okay.
Hello.
We can hear you now.
Okay.
Hi,
And
Dave.
what was the question, Herb?
The question is, how old are you?
77.
Well, same as me. And where do you live?
In Minnesota.
Okay. And tell us when you were first diagnosed, how long ago and when you were diagnosed with prostate cancer?
March of 2019.
Okay. We are on the same path here, man. And what was your Gleason score at that time?
It was between 7 and 8.
Okay. And where was that diagnosed?
In Minneapolis at a urologist and confirmed at Mayo.
Okay. And what was your PSA when you were diagnosed?
27.
Okay. And how was that picked up?
Through a standard chest X-ray regarding an orthopedic injury.
Uh-huh.
And it was noted that there were metastases.
Uh-huh. So you were literally diagnosed metastatic based on an X-ray.
Well, there was a follow-up biopsy. There was a suspicion with the chest X-ray with suspicious lumps or shadings, whatever, and then that led to further tests and the diagnosis.
Right. So then they did a biopsy, and then they came back with the Gleason score. And did they do any other kind of scans other than the X-ray to look at your disease?
Yeah, they did the standard CT scan, abdomen, and a bone scan.
And what did the bone scan show?
Multiple metastases, primarily spine and ribs.
Right. Okay. So based on that, what in 2019, what did they pick for your treatment?
Well, I started with ADT, and then that summer had chemo.
Okay. The chemo was basically docetaxel?
Correct.
And how did that go?
It went well. PSA went down.
And what did it get down to?
Well, with initially the ADT brought it down under 4. I don't remember the number. And right now, after chemo, it was in the 1 0.0 range, I believe, to eventually went down to 0.4.
Okay. And so then after the chemo, that you stayed on ADT?
Yeah, about 6 months ago, I went to intermittent.
Okay. And what's the results of your current PSA?
Well, the last PSA was still pretty low. It was, I think, around 36.
36?
Without, yep. I'm sorry, PSA, I'm thinking testosterone level. PSA is, last check was 0.5.
Okay. And it's sort of more or less stable.
Yeah.
So did you have any genetic tests at all on either you or your disease?
Right. And there's no treatment suggestions based on the genetics, and there's no BRCA1, BRCA2, or other gene that would suggest
so who is
cancer.
you? And do you have a current, like a medical oncologist currently?
I use a Minnesota oncology.
Uh-huh. And is your doctor a GU oncologist?
It's one of his specialties is prostate cancer, but he doesn't restrict treatment just to that, as far as I know.
Uh-huh. So he'll treat all kinds of cancer.
No, he'll only treat certain types, and all I know that the prostate cancer is one of the primary ones he deals with.
Okay. So right now you're off. You're off of ADT. What, you've had Lupron injections or something like that?
I started with Firmagon for 2 months, which
right,
were quite disruptive to my the side effects on the subcutaneous, and suffered side effects for probably 12 to 18 months just from those 3 shots, 2 initially and 1 subsequently, and quickly went to Lupron, and have had better luck. The Lupron is a muscle injection and not the subcutaneous.
Right.
I think it's called what is it called? EL something, the subcutaneous.
Right. So the question I had is, when was your last Lupron shot?
I'd say about 6 months ago.
Okay. So basically, right now you're not on any treatment at all.
No active chemical treatment. I guess I appreciate the presentations, and I guess the only treatment I might say is that I'm doing a lot of exercising, and hopefully doing some good.
That'll make Jimmy happy. So
yeah, I hope so.
So I guess having all that, understanding where you are, what are the questions you might have for us?
Well, I found the presentations very interesting and appreciate all the work that went into them. My takeaway this evening is that there's a real kind of an assumption that testosterone makes prostate cancer grow, and I noticed in the last month or two I've read some material published by a Harvard Dr. Morgental, who I guess is a bit controversial and suggests that testosterone is not linked to prostate cancer growth. And in fact, one thing that comes to mind is that people, the lower the testosterone, the more likely they are to be subject to high-risk prostate cancer. And so he does, one of his areas of treatment for men in particular is testosterone replacement therapy. And so over the years, he's studied whether that added testosterone makes prostate cancer worse, and his results seem to suggest to the negative, and I know that my quality of life and many of, I think, the members in this group who are on ADT could perhaps benefit from more testosterone in at least the quality of life area.
I guess I have to say that if you've heard the presentations, it's really pretty clear that testosterone is what's driving prostate cancer, right? This is not a subject that's a subject of current debate, because if it were, I mean, the earliest treatment for prostate cancer were castration, which took away testosterone permanently. The most frequent treatments for cancer now are based on androgen deprivation and second-level androgen-directed drugs. So I don't know that there's any data that would even suggest that giving testosterone is a good thing. And I would, Len, would you please comment on this?
Yeah, I was just looking up Dr. Morgental. Yeah, he's certainly out there on the fringe. I guess that there was a video of his presentation about testosterone and prostate cancer, but of course I can't listen to it now. Yeah, I mean, I agree with everything you said, Herb.
I think this guy, I would say, needs, he is not somebody we would put a lot of faith in, to be honest, David.
He's a Harvard-educated doctor, so I mean.
Hey, if you look at all there are a lot of Harvard-educated people in this world who really have gone off the deep end in many different ways. I mean, I hate to tell you.
Yep, that's true.
And this is not, I don't think anybody Len said it, I said it. I don't think anybody in this group should even think about this as a potential therapy. Yes, there are some physicians who would say, and they've tested it, something called bipolar androgen therapy, and that's giving testosterone in very high doses. But it's based on the theory that if you do that, you can rejuvenate the receptor to the point where it becomes important to control the cancer, not because testosterone isn't driving the cancer. So I really would have to say we can't countenance Dr. Morgenthaler here. It would not be part of anything we would want to endorse. And I would hope.
Can I add something, Herb? Morgenthaler's name always comes up when guys are talking about alternatives to hormone therapy. His name comes up so much in the forums that I've read and everything else that I don't want to call him a lone wolf, but I don't see a whole lot of others lining up with his points of view. But he is always cited, it seems, when this comes around.
I actually never saw his name because I guess I'm just reading the scientific literature. So
you're not looking at YouTube, Herb.
Well, I don't look at YouTube very much.
Good for you.
So David, I guess the other concern we have is your PSA currently is 0.5.
Right.
Wasn't it 0.5, Herb?
Yeah, 0.
Oh, I'm sorry. Well, 0.5 or 0.5, either one.
Right.
Okay.
0.5, and to us that isn't zero. Right. To many of us, that would not be a sign to give up on ADT or therapy.
Well, my doctor at the University of Minnesota is Charles Ryan, who's the president of the Prostate Cancer Foundation, and he seems like it's a logical possibility. I still have my prostate, and I'm giving off PSA for various reasons, and it isn't, I haven't been, hasn't been removed. So I'm on no other treatments, and with that kind of a level, stable PSA, he thought it was a very reasonable way to go, and that if it started to go up, he would probably restart the ADT.
Okay. So do you have any, so again, what questions do you think we can answer now based on this?
Well, I really don't have any questions. I saw the link to this meeting, and I thought it would be very interesting to see some of the results, and it has been. I appreciate the summaries of some of those presentations.
Great. Well,
I have a question. I have a question for you, Dave. Have you ever been on either abiraterone or enzalutamide or a similar second-line anti-androgen?
No.
Okay. Sort of interesting because somebody with that type of disease, as you described, would probably encounter it at some point. How long have you been seeing Chuck?
About since I was diagnosed.
So, but you mentioned you were with Minnesota Oncology.
They're the ones that administered chemo and so forth. Chuck is kind of my, if you will, consulting oncologist. I've chosen not to do treatments at the University of Minnesota because it's less convenient than Minnesota Oncology, which is probably the largest private oncology organizations in the Twin Cities.
Yeah, we're familiar with them. I mean, there's a really good oncologist from Minnesota Oncology who just in the last few months has gone over to join Chuck. Frankly, before Chuck and Antanarakis got there, he was probably the only GU med onc in the whole of the area, and we've known him for a really long time. He's a really good guy.
Good.
So I'm just trying to remember his last name. Stuart.
I think I know who you're talking about. I can't pull the name myself.
Yeah, it'll come back to me.
Right.
I'll tell you in 1 second because I do know how to find. But that said, it's just puzzling to me that they've never added, especially with Chuck, that he's never added abiraterone because he's Dr. Abiraterone, as you probably know.
Right. Well, I think I could perhaps speculate is that when I was down to Mayo and saw Dr. Pagliaro, who came up there from the cancer organization down in Texas. What is that, Rick? That's the big MD Anderson.
MD Anderson.
Yeah, and I think that their thinking was that I should probably try the, I had various options for initial treatment, including abiraterone, enzalutamide, chemo, so on and so forth. And their thinking philosophy at Mayo was that if you do chemo before you do any of the AR treatments, the likelihood is that if you ever need to come back to chemo, it will be more effective. And if chemo by itself is effective, you don't need to go to step 2 until step 1 is showing some signs of not working.
Yeah.
So,
look, you have abiraterone in your hip pocket. Stuart Bloom is whose name I was trying to remember.
Yeah, right. That name is familiar.
Yeah, he's a very good doc.
Well, good. And I think, Rick, you had mentioned, I don't mean to, for other people in the meeting, but University of Minnesota was, I think, and Chuck was very instrumental in getting the doctor from John Hopkins. The last name starts with A. He's Greek and very well known around the world. So interestingly, he moved into a house not too far away from my son.
All right. Well, yeah, he's a good doc, but I think look, Chuck Love, I've known Chuck since 2008 or 2009.
Wow.
And I used to live in the same place, same town he lived in, and I know him quite well.
Wow.
And he's a terrific doc, and he loves to treat people, to treat men. And so I doubt that he'll give up his clinical practice totally. He may do. I know he's not for a while, but if you have to move over to Antanarakis or Stuart Bloom because Chuck disappears to Los Angeles, it wouldn't be the end of the world. So
well, that's encouraging. I hope that Chuck decides to stay. I know he dearly loves treating patients,
Right.
clinically. Yeah.
Anyhow, I think, Dave, you can please continue to join us and keep us posted on how you're going. And you can obviously learn some more from listening to the other guys here at times. So,
Absolutely. Thanks, Herb. And I apologize for taking too much time if that's the case.
We're good. We're good.
No worries. But the one thing we do need from you, Dave, is your email address so that we can send you reminders. So if you want to put that in the chat window or send it to me directly, we'll sign you on, and then you'll get a reminder each week before each meeting.
Okay, so the list that I'm on right now is something different apparently, because I'm getting those reminders.
Oh, are you? Well, then you are already on there. And forgive me, I
appreciate your mention, but I that's how I found out about this meeting.
Okay. Well, I suspect you must be on. I'll check and I'll send you a message if you're not. Okay.
All right. Thank you very much.
Okay, great. We'll be in touch. Okay, let's move on. Frank, I promised you time. Here you are.
Okay. I had my 3-month checkup with my oncologist on January the 4th, and it was a great way to start the new year with what was found. Blood draw, PSA is undetectable. Testosterone is 11. And all the rest of the blood marks are where they should be. So it was a happy appointment. We scheduled my next one for 3 months, and I'll be on that 3-month cycle following the cancer. So that was really great news. But anyway, when you go to those, you're just sometimes expecting the worst, but you get the good news, and it's very much appreciated. I did a couple days later get a slap in the face. I came down with a bad case of sciatica that I'm continuing to fight off, and not successfully. So I'm going in Thursday of this week for an epidural into the L23 of my back. Mm-hmm. So that's been messing with me for the past 2.5, 3 weeks and causing problems.
Have you tried any physical therapy?
I can't even, it hurts to walk 10 steps.
Huh.
And the pain level is very, very high on it. But they want to start me as soon as I get the epidural. They want to start me on water exercise to start to work the back and to get that under control.
Okay, well, hopefully that will work. The epidural, unfortunately, are a temporary solution to a more serious problem, but it'll if it relieves the pain and gets you into a position where you can do some therapy, that's good.
Yeah, the neurosurgeon wanted to do that after I get the epidural because he expects the success of the epidural, and then that will allow me exercise with what I have.
Good. Okay. Any comments? From anybody?
And just to update, just with everybody, since I completed my chemo in April of last year, I've been on Orgovyx, and I've been on enzalutamide for each month since then.
That's great.
Frank, I lost contact, unfortunately, for a moment, and I didn't hear the result of your PSA test. It was what, 0 point?
It was as low as they could detect at the James,
Okay.
which was less than 0.06.
Okay.
Is all that they share, and it was there, and my testosterone was 11.
Uh-huh.
We like that. Very good.
Yeah, it made for a great start of the new year.
So, but you're on Orgovyx. Is that right, Frank?
Pardon me?
You're on Orgovyx.
Yes, I am. I have been since March, where my doc replaced Firmagon with Orgovyx, and I've been off the 28-day shots and gladly on the daily tablet.
I mean, I guess I'm glad that you're doing oral and that your PSA is so low. I guess I'm also a bit concerned that testosterone isn't 0.
Well, again, my doc says he's satisfied as long as my testosterone stays under 25.
Okay.
He's satisfied that the meds are doing their job.
Yeah, I mean, Herb, I'm not sure that we ever really hear of anybody having 0 testosterone. At least I don't recall it. Occasionally we get single numbers.
My numbers are always unmeasurable, below the detection of the assay.
Well, I would find out what the detection of the assay is. I would suggest, because normally this is pretty normal, T11, some single numbers, but
okay.
I've never heard it less than or equal to 0.
Okay. I stand corrected.
I have a question for Captain Fabish. How are you doing as an Orgovyx ambassador?
Well, my wife and my wife Gail has been accepted as a ambassador for caregivers, and we're both scheduled to go to Orlando in February, but that would be our first time, and the only thing now, it's pending my sciatica and also pending what's going on with the virus. And
right.
But that's the first schedule of it, and we've been going through some training sessions for it. So it's going well, and I like the idea that we can speak for that med and what it's done for me.
Well, I can only tell you that both Herb and I and John Ivory are also in a holding pattern because we have an invitation to the GU Medical Oncology in February conference in San Francisco in February, and I don't think any of us want to go if COVID is like what it is right now. So we're very empathetic, and we would love to attend that. Believe me, that's a very prestigious
San
conference.
Francisco would be, I love San Francisco, but not in the middle of Omicron.
Yeah. Yeah, it's very contagious, and right now I know I don't need to come down with it. So it's right now it's up in the air, but we're very appreciative that we can speak for Orgovyx and what it's done for me.
Great. Okay. Thanks, Frank. And keep
Sure.
us in tune. Steve Saft. Steve, before you go to sleep, are you?
Hello. I guess you can hear me now. All right.
We can hear you.
So my update is that I've had 6. On January 6th, I had my 6th cabazitaxel treatment infusion. I continue to feel pretty good. As I guess you can see, I have all my hair, but in addition to that, I feel pretty good, although I get more tired quickly. Unfortunately, there's no labs or data, or now I took scans last week as well that are supporting the fact that it's doing anything other than slowing down the progress of cancer. I had a CT scan abdomen, pelvis, CT scan chest, MRI of the lumbar region. What am I forgetting? And nuclear bone scan. And all of them talk about progressive osseous sclerosis with increased uptake in a lot of different places. My PSA is hovering in the 125 to 140 range now for about a month and a half, 2 months. And ALP is increasing. I think I get labs before every treatment, so alkaline phosphatase is in the low 300s now, and so I am starting the process of trying to figure out what to do next, and assuming that this is not going to work for me. So all of the presentations tonight, I think, were very timely for me, and I'm looking forward to getting the slide decks and the tapes and being in a position where I can read it. My reading comprehension is much better than my listening skills. So I'm certainly looking forward to that. And so the update is really that cabazitaxel was easy to take. I think it has slowed down the progress of the cancer, but it hasn't reversed it. And so I've got some work to do and some questions to ask, and to see, how long to keep going with this and what to do next. I'm disappointed, but I take, some comfort in the fact that I feel pretty good. I'm still working out. I did 48 minutes on my elliptical machine yesterday while watching my Eagles get blasted. So, I hope to continue to work out. It is starting to hurt a little bit more, and we'll see if radiation therapy is in my future. And I expect that there will be additional updates in the future, and hopefully one of these days it'll be good news.
Yes, that's what we hope. I mean,
So,
the issue for me that I mentioned to you in the email, yes, cabazitaxel is easier to take than docetaxel. I wonder if it's less effective.
I actually had one consultation with another oncologist at University of Pennsylvania. I asked him that question, and his understanding, like I think all of ours, is the taxane family is pretty similar in what they do and how they attack things. And for whatever reason, it doesn't seem to be doing much for me. I've had somebody suggest to add carboplatin to the cocktail, or possibly radium-223. I think all of those will be very toxic, and I really, as I try to figure out what to do next with the help of the oncologist I've been seeing for a couple of years, as well as others that I have reaching out to contact. There's always the balancing act of what can work, what kind of risks to take, what the probability of success is, and how crappy I'm going to feel when I do these.
How has cabazitaxel affected your hemoglobin levels?
My hemoglobins have been slightly low since I started hormone therapy. Red blood cell, hemoglobin, and hematocrit, all three are maybe 5 to 10% under the low end of normal. Nobody ever seems to be concerned about it. White blood cell count is fine now, continues to be. The other thing that we'll be looking at is I did a genetic test with Foundation One, and one of the mutations that showed up there, which there was no treatment for at the time, is EP300. And there is a clinical trial at Jefferson where I'm being treated, specifically targeting that P300 mutation. I did look back on that, and there's other mutations that I think they're starting to do some work with. So I guess I'll challenge everybody to take a look at that as well. But I think that the next step takes time to figure out, and then get it approved and whatnot. So I am pushing Dr. Kelly, who is my oncologist, to help me prepare for that now, on the theory that being a little too early is way better than being too late.
Right.
So, Steve, I would like to follow through with a couple of things here, just to get everyone else's feedback, really, to put some ideas out. As I recall, you did not start chemotherapy until you actually joined this group. I remember, you hadn't done chemotherapy when you first joined the group.
Right. I was one of those ABC club members, right. And turns out that that probably was a pretty big mistake. But for a couple of reasons. One is, at least cabazitaxel has not turned out to be that terrible.
Right. So you were on abiraterone originally, correct? With Pharmadol.
That worked fairly well for a little more than a year.
Okay, so it was after a year that the abiraterone stopped working. And how long were you on abiraterone before you stopped taking it?
I started abiraterone in May of 2019, and I stopped taking it probably in September, October of 2020.
So only about 15 months then, huh?
Yeah, my PSA had skyrocketed from 6 to 47 between April of 2019 and May of 2019. And then once I started Firmagon and abiraterone. It went down to 4 and stayed there through August of September, July, August of 2020. And really, I don't know if I told you guys, but my brother had brain cancer during 2020, and he died on October 6th. The funeral was October 9th, and I actually went for an Oxyman scan at like 5 o'clock after his funeral, and the results were not good. That's when I stopped abiraterone.
So, and did you do enzalutamide after that or not?
No, I went right to the AMG 509 clinical trial. And actually,
I would just say, I mean, so you don't have an excessive period, but I would really like to try and figure out if your cancer is changing, because it seems like it is, but it wouldn't. That's not reflected from your history. And
what do you mean it's not reflected from my history?
Well, normally when we see the cancer change, oftentimes, normally is a bad word, but oftentimes it's as a result of men having been on one drug for a long period of time.
Well, I've been on Firmagon for 32 months.
Right, but not so much from the primary hormone therapy, but it can be from the primary hormone therapy. It can be. But it's really more from extended use of enzalutamide or extended use of abiraterone for like 2.5, 3 years, 4 years. We often see it change. See in men who have been on that, we see a change in the type of prostate cancer. Now, it can also be from hormone therapy. I mean, way back when I was diagnosed, and we didn't have abiraterone, and we didn't have enzalutamide, we would see this happen as a result of extended use of first-line hormone therapy. So the cancer can change in response, but nowadays we don't hear that often. And I think that what I would be drilling down on is trying to find out if the cancer looks different now, if it has a different genetic sequence. I mean, some years ago, the Dream Team West came up with this theory, which they substantiated by looking at a whole bunch of samples and looking for common genetic sequences, that there were 50-odd gene mutations that were typical of the cancer as it morphed from being adenocarcinomic, sensitive to hormone therapy, to not sensitive to hormone therapy anymore. So we know what those mutations are. I can't tell you off the top of my head. And I think that, it would be good to be asking the docs, well, do we think that this is a different type of hormone cancer, a different type of prostate cancer? And if it is, should we be treating it differently?
And I mean, are you suggesting, just to clarify, should I be asking them to take some sort of a new genetic test? I did have a Guardian, I think it's Guardian, blood test at the end of 2020, which didn't show anything actionable. But the only way to get it.
The last time. So, I mean, I think I'd do a couple of things right now. If that was the last time, I definitely would consider getting another NGS test, whether it's with Guardant, whether it's with Foundation Medicine, or any of the other providers. I would definitely suggest that to see what it shows.
How about
second thing is,
one of the tumors?
I might consider doing it rather than as a blood test, doing it if you have something that can be easily biopsied, doing that and having somebody like Epstein look at it under the microscope and see if it looks different.
Who is Epstein, aside from my great-grandmother?
Who is Epstein?
Steve Epstein, he is the premier prostate cancer pathologist at Hopkins. So he has his own website where people can send him their slides for second opinions, and a surprisingly high percentage of time he revises the original diagnosis, either up or down.
Yeah, but hold on. That's not really what we're talking about here, Herb.
Well, but
we're talking about the morphology of the cancer, right? Which is a little different. And I think the point is that Epstein is probably the premier prostate cancer pathologist worldwide. We're very honored because he's actually just agreed to join our advisory board. And we have a lot of contact with him, especially in the lesser groups where the men are trying to figure out their Gleason scores. But I'm thinking about him looking at this from a different view. And one of the nice things is he loves speaking to patients, which is very unusual in a pathologist. And there are any number of our patients that he's spoken to. So if we got this pathology done and we sent it to him, we could certainly arrange for a conversation. You email him and he calls you. He usually does it on his drive home, except that he fell and cracked 5 ribs about 2 weeks ago. So we think he's working from home at this point in time.
Right. But I actually, my next door neighbor is who I used to babysit for when I was growing up is a prominent doctor at Hopkins. And so that's great. I will figure out a way to approach Steve Epstein.
Well, it's not Steve, it's John Epstein, and you don't need to approach him. The first thing you need to do is talk to your doc about getting a biopsy.
Right.
When you've got that biopsy, you ask it to be sent to Epstein's lab. And once it's sent to Epstein's lab, you give us a heads up, and then we can take it from there. So you don't need any grease here. We can provide the grease for you.
Okay, I comprende. Thank you.
Okay.
Any comments from anybody for Steve?
I have a question. Herb. Steve, did you do docetaxel before you did the cabazitaxel, or did you go straight to cabazo?
No, I mean, I did, as I mentioned, the immunotherapy from December of 2020 through June of 2021. And it was failing at that point. And then somehow or other, my doctor got me approved for cabazitaxel as a first-line chemotherapy. I'm not sure how or why.
Okay.
Okay. Any other questions? Well, Steve, please keep us informed and bring back any questions.
Yeah, I mean, I will, and I thank everybody for their patience and listening, and for this being such a high-level group with such high-level discussions. I've really learned a lot. So thank you all.
All right. I guess it's my turn. So I wish I had good news like Frank. I don't. At the beginning of the year, we did a PSA test, and all of last year it was hanging around 1.5, and then at the beginning of the year, it kind of kicked up to 3. And so that was the beginning of the end of December, beginning of December. And then, so now the beginning of January, like last week, we did another exam. Instead of waiting 3 months, it was a month. And so it's now 4.1. And the technetium scan showed new osseous lesions in places that it wasn't there the first time, including ribs and vertebrae. So I have now passed through the gates of castration sensitive to castration resistance. And we did an FMI scan, and the FMI test showed an ATM mutation and then an interesting mutation in the androgen receptor. It's just T878A. It's just letters, but it makes it less sensitive to enzalutamide, but potentially more sensitive to darolutamide. So the bottom line is I'm now castration resistant and we've got to move on to another therapy. I'm still taking Abby just because I didn't really believe what my oncologist at NIH said to me, which is to stop taking it. So I took Abby. Last week we met, so I had also been sort of not quite kicked out of the mothership, but because the next therapies that I need are not going to be done at NIH, I've now sort of moved off to a closer relationship with Hopkins and Dr. Carducci. And I will tell you that we had a very long video conference with Carducci. He asked all the right questions. One thing I didn't know, for example, and we didn't know, was that Hopkins is a site for the managed access trial for lutetium, if it ever comes back. And so he immediately put me on the list for managed access to lutetium, should we need it, and should it come back. But in the meantime, what do? We're moving ahead with Sipuleucel T, or Provenge. It's sort of the sweet spot for Provenge in terms of my PSA and the likely life-extending effect of Provenge. He, of course, as Larry Fong has said, there's really no way to measure that Provenge is working. You sort of take it on faith that it's going to work for you because it's a group statistic that it extends life, and presumably it's going to extend life for you. But he was pretty clear that it's not going to change your PSA, not going to change the bone scans, it's not going to change any measurable parameter. But from what we know from the people who took it here and from what the literature, it seems like the right next step for me. After that, we don't know. I mean, I'm still taking Abby, and we discussed whether I should continue to take Abby. I mean, my theory is that I can't believe that every prostate cancer cell in my body automatically became resistant to Abby. Maybe there's a clone or two, but probably there's something sensitive. Whether we switch to something else afterwards, I would like to push for a trial of darolutamide, but his attitude is let's go through Provenge first, and then we'll see what we can do next. So I will say this about Carducci. My wife thought he was terrific. I think he asked all the right questions. He made all the right suggestions. But there is one thing, and this is the thing that Rick has noted time and again, he didn't make any eye contact. So if you're looking for a warm and fuzzy physician, this guy is not it. I didn't feel like I was getting slighted or anything. Nobody ever told him he's got to make eye contact. My wife is threatening to do it next time we see him. But we'll see. So that's where I stand. And so we're at a crossroads here. I have to say, my news it didn't start the new year off right. And one can only hope for the best as this thing progresses. I do have a radiation oncologist involved, Collins at Georgetown, and he's going to look at the scans, and we can decide, for example, if there is something that he thinks should be radiated to prevent future damage, we'll do it. So that's not out of the question. The other thing that's interesting that I got from Carducci that wasn't said specifically, he doesn't think that radiation is whack-a-mole. He thinks in certain circumstances it can be helpful. And we didn't talk specifically because we're not up to that point yet. But I got the distinct impression that he didn't think it was that a more
So that's what they call the abscopal effect.
Well, we don't know if it's abscopal or whatever, right?
And the abscopal effect is, I mean, if radiation is effective, then I assume you're talking about some sort of SBRT or IMRT and radiating the lesions. Is that right?
Right.
So if it's effective and if it has a wider effect,
yeah, well, we don't know.
The only way that we know that that could possibly be is through something called the abscopal effect, which Len and I have been hearing. And hold your thoughts, write them down. You can come back. I'm not gonna cut you off. Which Len and I have been talking about going back probably since Len and I started working together in 2014 with Lupron Gym. And what we've seen probably in the last 2 or 3 years is that it seems to be getting more credence. Len, do you want to just talk quickly about the abscopal effect?
Well, I mean, I think the person who mostly talked about it before was Dr. Mark.
I'm going back long before Dr. Mark was even diagnosed. We're talking about abscopal
conceived.
Yeah, not that long.
How many?
Len, first of all, let Len just explain a little bit, and then we'll go to Dr. Mark. But Len, go ahead.
Yeah, well, of course, the theory is that you destroy some lesions, hopefully not more than 1 or 2, because you don't want to weaken the bone marrow production of T cells and white cells. But let's say you hit a lesion and the cells die, the tumor-associated antigens go floating out through your blood, and then the T cells say, hey, we got to attack this wherever we see it, and so they do that. So the thinking, I believe now, is that if you're going to use, if you're hoping for abscopal effect with spot radiation, it's probably a good idea to administer one of the checkpoint inhibitors at the same time to enhance the T cell response.
Of course, there really isn't any clinical data.
Right, but there are current clinical trials.
Right, but no real hard data yet.
Right.
I mean, I think the other part of it, the abscopal effect, might be, for example, if you use immunotherapy first, something like Provenge, which primes the immune system, it primes T cells, right? And then you hit it with lutetium, right? That could be sort of a double whammy if taking advantage of the abscopal effect.
Right.
I mean, that was in my head, that if you're going to try to trigger the immune system with radiation, that might be the way to do it.
Herb, how many lesions do you have distally in the bone?
Many.
So it wouldn't be considered oligometastasis. And from what I understand, the trials that looked at this were in situations with oligometastasis and not with multiple mets.
No, this is not oligo. From the get-go, it wasn't oligo, unfortunately. So, I mean, what can I say, guys? I think I actually, we've been talking about it. I've been talking about it with Rick. I think this is the best solution. We can hope that lutetium, the next step, and everybody said lutetium probably should be the next step, and hopefully it'll become available in time for me to use it, but we don't know. We don't know when it's going to be available. But
so I have a question for the other gents that are on this call tonight, and several of you have done Provenge, Sapilusalti. Has anybody been advised to stop their second-line anti-androgen when they started Provenge? Has that ever come up with anybody else who's done Provenge? Okay, and who's done Provenge?
No, Rick,
Who on the call?
I've done Provenge, but I did it before I was castrate resistant, and I didn't drop Lupron. I knew you were talking about second line, but I wasn't on a second line at the time. So
Right. So anyone else? Carlos, were you on a second line anti-androgen when you did your Provenge?
Is Carlos frozen?
He's not frozen, but we can't hear him. I can see his lips moving.
You're mute. You're not muted. I mean, you're not muted, but we can't hear you.
There we go. Sorry about that.
Yeah.
So no, my situation, yeah, I stopped the darolutamide during that period of time, and I didn't want it complicated or to make me feel any worse than I needed to, and have since restarted.
Okay, so you did stop. Anyone else on the call has done Provenge?
Carlos, was that something your doctor recommended, that you stopped the darolutamide during that period? Is that something that you worked out with him?
No, it was, my doctor didn't recommend it, but he didn't say, I don't think it's a good idea. So he said, go ahead and give it a shot. And, Provenge is not we will be doing something soon after Provenge. I'm going to go ahead and take a couple minutes since I do have the floor. I did have a discussion with him today. My numbers are pretty much the same. They've just sort of creeping 0.4, 0.5, 0.6 over the last 4 or 5 months. And at this point, it's a matter of waiting to see if the numbers keep changing.
Carlos, let's just finish. We've got you down the list. We will come back to you. Let's just finish with Herb. Okay.
Okay.
If you don't mind.
Sorry, can I say something?
If it's related to this topic, and really what we're just trying to find out is whether this is common, because I had not heard of it before, but it may be that this is common practice, that when you go on Provenge, they ask you to stop everything except your LHRH drug. That's what we're trying to find out right now.
Yeah, I understand that.
Okay. Go ahead, Larry, if it's related to this.
So I wanted to, you said that your doctor wanted you to do Provenge before starting darolutamide. Is that correct?
You're talking to me, Larry?
Yes.
No, yes. Darolutamide was just sort of a potential therapy. I mean, the common wisdom is that enzalutamide after Abi doesn't do all that much for most people, right?
Yes.
It's about a low percentage, but it's clear that from the presentations that we've heard and the data, that Provenge, when your PSA is low, relatively low, and you just turn castrate resistant, seems to have its maximal life extending effect.
Yes.
So the question is what we do afterwards. Now, obviously, if I had my druthers, I'd go directly to lutetium.
Yes.
But we may not have my druthers.
So you'd rather do lutetium before darolutamide?
Yes.
Okay.
I think I've talked to several oncologists, and the theory is, look, it went through the trials, like we had the trials, the results of the trials, and all those trials show that it worked, and we've seen it with other people here on the group. And the only issue is, how long it will last after you get it. And, everyone says, well, we don't have the data, but it's more likely that if you take it earlier, it's going to have a more prolonged effect. So I'm going along with it, even though there's no data.
Yeah, and it's not easily available to just get into lutetium without a trial at this point.
No, it's not available in the trial. It's not available, at least in the U.S., period.
Oh, they're not doing any lutetium trials? I thought they are.
Well, no. It's not available to new people. People who are already in the trial are getting it, but nobody new is getting in.
And you were saying that is maybe temporary because of availability of.
Well, I think it's temporary. So my own sense from talking to people is that, yes, it's temporary because they've applied for FDA approval. And my own feeling is that they're probably feeling, why give it away when we can start charging for it soon?
Okay.
No, I have a different view. I've said it on this forum before, but my view is it's not quite as cynical. I think that there's a logistical issue in administering it to the patients because there aren't enough radionuclide technicians, and they're training more because Novartis would look very dumb if it got approved and it could not get delivered. It's not an issue around making the lutetium or making the ligand. That's my personal view.
Right now.
Okay, thank you. I don't want to belabor this.
How can you tell Provenge is working and when you need to move on to the next drug?
Okay. So Provenge is a short-term treatment. It's 6 weeks. They take out your cells. They put them. You've heard the Larry Fung webinar, right? Take out your cells, prime them to prime the T cells, and then they put them back. So it's not like it's not like when you say it's working. The bottom line, it's a one-shot treatment, Jeff, that you have to make the assumption that it's going to help you.
When do you decide to move on? At what point do you take scans?
After you get 3 injections, after they return the cells to you, after the 3rd cycle, you're done.
Okay.
Right. It's not
so you move on then.
It's not a sequential treatment. It's not a treatment like most other treatments. You take it, you see how it impacts you. If it doesn't seem to impact, you go on to the next one. This is, think of it as an adjuvant treatment.
Right.
It's a treatment that, in our view, in my view, for whatever it's worth, the evidence shows most men should get it, and they should get it as early as they possibly can. It's approved to be gotten if you are castrate resistant, and there are, I think, 2 successive increases in your PSA. You can apply for it. It can be approved. And it's something everybody should get. But do you know if it has an impact? No. At the same time, the studies show that men who got Provenge lived longer than men with comparable disease lived significantly longer than men who didn't get Provenge.
Right. So while we're on, I think, any other questions for me or comments?
Herb, I put a reference in the chat box.
Thank you.
Okay.
Except Xofigo, some people think it should be last resort.
Well.
And Rick thinks it's not, it's a dead drug. So I wonder if Provenge plus lutetium will become the successor to that trial.
Yeah, probably. That's a good idea.
So,
Herb, this is Cal. I just want to ask, so I'm guessing you took chemo quite a while ago, is that correct?
Right. I had 3 rounds of chemo at the very beginning of my diagnosis, which was the fall of 2019. And after 3 rounds of docetaxel, my oncologist looked at me and said, "We can't give you another round. You're too beat up." So I had all these side effects. I was in the hospital with febrile neutropenia. I had what was called hand and foot disease reaction. And so they switched me over to Abby after 3 cycles of chemo, saying, well, you know, the chemo worked. It really knocked my PSA down at the time. And so if we need it again, we can use it again after you recover.
Thank you.
Herb, why wouldn't you go to cabazitaxel after the docetaxel? If the docetaxel is working but beating you up too bad.
Well, right. I mean, we might. I mean, I don't think that's not an unreasonable thought. I mean, it's interesting that my medical oncologist at NIH says she can't see any difference between cabazitaxel and docetaxel in any way, and that may be just her sample of patients, but that's what she says. I mean, Hopkins. I'll have a wider. I mean, again, this, having a coordination between Hopkins and NIH, I'll have a more access to more opinions and more treatments.
Herb, this is Carl. I had Provenge, and I had it back in January and February of 2019. It was just at the time that Abby was failing me after 6 months. And at the time that I had genetic testing, it was determined to be BRCA2 positive, and it was about to start the PARP inhibitor. So, you know, to Rick's point, I guess, I don't know if it was planned by design, but the Provenge treatment I had was right at the time that we stopped abiraterone and just at the time before I started the PARP inhibitor.
Mm-hmm. Well, thanks, Carl.
Herb, having met your wife, I don't think you should have any problem straightening out Carducci on the eye contact thing. My wife hates it when I don't make eye contact with her. So if your wife is reluctant, I'll have my wife talk to him for you.
It was really, I mean, at the end, I actually got him to laugh, which I thought was a major achievement.
Maybe he's on the spectrum.
He could be. We've thought about it. He could be on the spectrum. It is not, I am not unmindful of that possibility.
Maybe I'm on the spectrum. I'll tell my wife that.
So anyhow, there are hopefully things that I am doing will have a positive effect in the future. So we'll keep in touch.
Go Provenge.
So with that, Ken, is Ken here?
Yeah, I'm still here. First, lots of luck with Provenge. I don't think I'll have any problem with it. Should be a breeze, and then you can move on to something else. Whatever it is, and you'll figure it out. For me, I did have, labs at the beginning of the month when I got back from the Northwest, and my PSA went up a little, so it's not making me crazy. At the moment, it's at 50. For some reason, chemo is still holding it, but not holding it as much as I'd like. Paul's recent comment to me from MD Anderson was, which, kind of took me back. He said I might consider doing lutetium in Australia. So in his head, I think it's going to be a while before it gets approved.
Wow.
I know, that's what I said. So I haven't asked him outright, and I probably will. I told him I'd stick with chemo another round and see what happens the next round or two. And, if PSA goes up a great deal, then yeah, I'll go to Oz. No big deal. They'll give me a medical visa, I understand. He says they've made a relationship with a good group there that he's comfortable sending me to, someplace in Melbourne.
Well, they really have done the most publishing in terms of lutetium.
Right. So he also made a comment about the whack-a-mole. His comment to me was, I have one bone met in T10 that's the most active. For some reason, the spinal column and chemo don't play well together. He said I might go after that particular met if it's possible. Like you, Herb, I've got lots of mets. Makes no sense to go after a bunch of them, but he said the truly bad apples, it might make sense to go after those.
Right. I mean, I had that same feedback from Collins. That basically, he says you can't do them all, but I want to do the ones that have any possibility of giving trouble in the future.
Yeah, I had very good results having radiation therapy to T12, and it's the one thing in these reports that says has improved and continued to improve since July.
Great news. So that's really my report. I'm not crazy about the whole thing. You know, I've been doing this long enough, just now gradually moving into my 6th year. And, you know, I guess I have the craziness in the bag at the moment. So that's it. You can move on to the next guy.
Well, thanks for the Provenge. I really appreciate the Provenge advice for sure. So, okay, next person, Vic, are you with us?
Yeah, I'm here.
Okay.
So I'm researching GUMOs at my local Center of Excellence, which in St. Louis appears to be the Siteman Cancer Center. Appears I have several to choose from. Just curious, from others' experience, do all the GUMOs at the Centers of Excellence work as a team, or should I be trying to, you know, narrow it down to one in particular, or any thoughts or suggestions in that area?
You know, I think I sent you some time back some thoughts on the GU medical oncologists at Sideman, Vic.
Yeah, he is one of several there, actually, I found out. And I'm just curious, you know.
I think I went through them all, and some of them didn't have great qualifications. You need go back and take a look at what I sent you.
Oh, I got
pulled
it.
them up.
Yeah, I still do have it. I was just curious, you know, about the others, why you maybe had ruled them out, or.
I think probably because they didn't have the experience. They were younger. I think the guy that I recommended was a MD PhD. And I think also I had looked at where they did their training. And if they'd done their training at centers that were well known for treatment of prostate cancer and other GU, I can't tell you off the top. I don't know that anyone else can. But my first
I'm not looking for a specific individual. I was just curious what everybody has done in terms of narrowing down, or if they know that generally the GUMOs work as a team.
Well, so that's a good point, and definitely let me address that from what I do. In the centers of excellence, some do and some don't. It's not consistent. It depends on the center of excellence. It depends on the philosophy. You know, at MD Anderson, I don't think they work that closely together. At other hospitals, they seem to talk to each other over the water cooler all the time. I think that when you select a genitourinary medical oncologist, you want to have the one that you feel is the best qualified, and also somebody that you can communicate with, and sometimes best qualified doesn't necessarily mean the best person you can communicate with. We've heard that tonight. So you have to find that right mixture of chemistry and experience. Now, how do you know about experience? You look at where the doctors have trained, because you know from where they've trained who they've worked with. If you find somebody who's worked at Memorial Sloan Kettering or UCSF or MD Anderson, you know the docs that they've been around. And from knowing those docs, you know you have a good feel about how they're going to treat. And so my recommendation would be not to think, well, it doesn't matter who, because they're all going to work together as a team, but to find the one that you like the best and try and get onto that person's panel. And I'd like other people to comment on this, because this is just how I do it, and everybody people might have different ways of going about selecting their docs. In fact, I know they do.
Yeah, I would agree, Rick. I mean, from my experience at various, being a faculty member at a medical school, I mean, many of the departments were collaborative and other of the departments were less so in terms of coordinating patient care. But I think if you pick I think in general, academic medical centers will encourage people taking their tough cases to their colleagues. If you gotta, that's where the importance of an academic medical center or a cancer center is. That, yes, you can get treated, but when they've got a tough question, they want to be able to talk to you want them to be able to talk to the next guy, say, what do you think? And, and some places are like that and other places not, and that you can't tell in advance.
Mm-hmm. Yeah, so maybe that's a question for me when I interview the guy I decide to go to first is, do you work with your colleagues a lot on cases?
Exactly. Do you have do you discuss cases each week?
Mm-hmm. Mm-hmm. Okay. Well, all right. That's very helpful. I seem to think that team approach is probably really helpful. And I'm hoping that they do that at Sightman. But if not, I might be seeking a third opinion at another center of excellence where the team approach is going on. I'm continuing to show good numbers in the castration sensitive stage, but realize that that's not likely to go on forever. So I want to make sure I get hooked in with a good GU team before I reach that castration resistant situation.
And in my own sense of having been to
Washington, anybody else?
Is they seem like a good collaborative. Okay.
Anything you'd like to contribute on this topic?
I wanted to say
yes, I don't know if it falls under this definition, but there is something called a tumor board that there are various centers that have where they do meet as a team and they review a specific patient's treatment options.
Right.
Well, thank you. I'll be sure to ask and see if they conduct those. Yeah.
I mean, the more academic centers will do it because that's what they're there for. Presumably, they're there to learn about the disease and their colleagues, from their colleagues.
Herb, I spoke some years ago or more recently with my oncologist at Sloan and discussed this idea about if I was brought around to, if they discuss my case in groups, and she said not usually. Usually if they have a doctor that feels like they know what they're doing with you, unless it's a case that they bring up, like you're saying, they bring up unusual or new or exciting cases, and then they really apply that team approach. But then it's Sloan anyway. In general, she said, no, they don't really discuss every case with anybody else much, unless it's something really special or it's something that's brought up. So,
Harry, have you ever read the allegory, How to Swim with Sharks?
I've heard about it, but I didn't read the allegory.
You really need to read it. It's very much, my wife was at Memorial and she had to swim with sharks. And
yeah, there are a lot of sharks there.
That is not, I would not call Memorial the most collaborative environment.
Yeah, exactly.
Yeah. Well, I think maybe at Sightman I might be riding with Avis. I'm not sure.
But I think Wash U, I have a good friend who was a professor of medicine at Wash U, and I think it is a collaborative place.
Ah, well, that's good news. I would hope so. Being connected with the Wash U School of Medicine, yeah.
Mm-hmm.
So Vic, I just pulled up this list. I think there's there's 6 or 7. And I think Aurora was the guy that I recommended to you, Vivek Aurora.
Correct, yes.
Picus, yeah, Picus has been around an awful long time. And unless you're in a really good place, I do concern myself about these guys that have been qualified 30 years or more, 40 years, because they sometimes they just don't always stay up. I think he was one of the people that was, and I think I tended to look at the people that were in the main campus as well.
Did you look at the Paczynski, or it ends with the SKI?
I did look at Paczynski, and I don't think I was impressed with where he trained. Let me see if he comes up here. Yeah, let me just see. But I think that was certainly one of the names that I thought of.
He was at one of the UC schools, I believe, as I recall.
Yeah, I'm having real internet troubles here tonight. It has come up. So Paczynski training. He trained at Stanford, and that. Yeah, I mean, I am not. I think that's probably why. I mean, I'm not a fan of how Stanford treats prostate cancer. I don't think it's a particularly strong center for prostate cancer. They have some. They've had some pretty screwball type people come out of Stanford. Doesn't mean that he is, but you know, I think that was probably that his training at Stanford just didn't do much for me.
Gotcha. Okay.
So.
Yeah, he was probably the second one after your choice that I was curious about. Yeah.
But you know, yeah, by all means meet him, and I mean, if that campus, if where he is more convenient, so I mean, if you've got specific names or something, and you want me to take a look, but happy to do it. But I know I did go through them all before, and that's why I suggested Aurora to you, because I thought he was the best choice of the lot.
Yeah, appreciate that, and appreciate the reasoning on it. Thank you for that. I've also reached out through the network to a person who working for a different hospital system that will refer the tough cases to Sightman to see if I can find out, you know, who the local MOs in the other systems are considered to be top docs there for prostate.
Okay. So
Thanks everybody. Appreciate it.
I guess there are some new people that joined us, and we're not quite done.
Herb, you've got a couple of people to go through before the new people. You have Carlos.
I think he's gone.
Okay. And you have the Mike Phillips and Tommy.
I think
if they're still with us.
Mike, did you want some time tonight?
No, I sent you a note. He messaged me, and I sent you a note that they need time.
Okay, fine.
It's Tommy, Mike's wife.
Hi.
Hi. I don't want to take time though, but I go to the Wives and Partners of Men with Prostate Cancer on Facebook. And today there were 2 articles posted from the NIH about quercetin. Quercetin, it's Quercetin.
Quercetin is it's an active, I forget where it comes from, but go ahead.
Well, when it comes from the NIH, is this simply in the research stage, or is it doing trials with, or
Tony, I haven't seen the article, and I don't know where you saw it. So I mean, it could be either. Generally, I mean, it's hard to say without actually looking at what you're.
Yeah.
Where you
well, it's probably not important because we probably can't access it yet. But they were both from the National Institute of Health, and I thought, well, that must mean that it's being taken seriously or something's being done with it.
So I would suggest if you have it, if you put the link in the chat window here, some of these guys like Len and Herb can look at this in a heartbeat, and they can tell you whether it's good or bad.
Okay. Thank you. That's what I wanted. I appreciate it.
So if you, and I'm not trying to shut you off, I'm just saying if you want an opinion like that, you know, the first thing to do would be to put it in the in the chat window. You know, it sort of raises an issue that's been a little sensitive for me and for all the moderators, which is that our time is it's getting pulled in a lot of different directions. And as much as we like to offer one-on-one navigation to everybody on here, we cannot do it. It's just not possible. And I cannot because I'm running a pretty large organization now at this point in time. Now, the best way to use the group is to come up with exactly what you're doing and say, I read this, what do other people think about it, and throw it on there. And then somebody's going to say, let me look at it and I'll get back to you.
Very good.
And because there are people like Herb who works at the NIH, and so he may have some insight. So it's very smart. All of us are willing to do one-on-one navigation, but if people want our time, then the way that AnCan works, we ask for a donation. We never turn anybody away, but we do that because our time is valuable and people need to respect that and not just say, oh, well, these guys know a lot, so we'll ship it over to them and see what they think. And as much as we'd like to do it, we just cannot. So we have to have some rules, and the rules are that the group is free and available and drop-in and available to everybody, and we can get as much done. If you prefer to have a one-on-one consult, then whoever the best person is, but just know that we'll give you the consult, but we ask you in return to recognize that our time is also valuable and make a donation to AnCan. But what I recommend you do right now is track down that link and stick it in the chat window, and we'll look at it in the next 10 minutes.
Chat window or mail it to me, and I'll look it up.
Email it to Herb. If he's kind enough to say that, then you're on.
Thank you very much.
All right. I think we got through everybody, but Kang, you joined late. We do have some time if you need it.
Thanks, Herb. I'm okay. I don't need any time. Thanks, Herb.
Okay. And then I'll ask once again, is there anybody who I missed? Okay, this is a surprising night. We thought it would go forever, and we managed to finish up in less than the full time. So
we haven't done that in a while, have we? Well, hold on a minute, because Tommy's still looking, and I'm willing to hang in here for the next 10 minutes so we can give Tommy a response.
And I wanted to discuss something, if I could, going back to.
Larry.
Yeah.
Go ahead.
Go ahead,
Okay,
Larry.
Discuss my. Sometimes I get a little confused in my thinking. I mean, I don't know if this is a complex or it's a simple question. So I know that when the cancer burden is low, it seems that Provenge is the most effective. My question is, in a situation like yours or mine, where we had a Christmas tree of light up in our original scans or mets we found with our disease, and I had very high PSA. Started the Lupron and did docetaxel as much as I could tolerate, and PSA came way down to the 0.1 level, luckily. And then over the years, it's been slowly growing little by little, to the point at which I'm starting to look at darolutamide. But back to this point is that if you had a very high cancer burden and there were multiple meds, do they know if Provenge is effective if your PSA has just been reduced because of your ADT and your chemo, or the Provenge is most effective when your cancer burden is low? The way I see it is that the cancer cells didn't die. Lupron didn't kill, maybe chemo helped, but Lupron didn't kill the cancer cells. They're still there in all those places that never really were very powerful or very strong. When you took the Lupron treatment, ADT treatments, you reduce the PSA, and those things are what they, I guess, long ago used to call remission. I don't call it, no one says that anymore, but they're quiet. However, slowly they start to wake up. Is Provenge as effective in that situation when the PSA is low, but you have those mets all over your body? Or is that still actually a high cancer burden that's being hidden?
So Larry, I know that the answer, Larry Fong may have the answer to that, but from listening, I mean, clearly nobody gets Provenge first straight away. They get it only when they become, other than Ken, who's lucky enough to get it early, most people get it when they become castration resistant. So and I'm assuming this, Larry, it's that they're castration resistant because their PSA is going up after they've had treatment that knocked it down when they were hormone sensitive. So I don't know the data, but my sense is that it's not necessarily related to your tumor burden per se at initial diagnosis.
Yeah, no, I understand. I just don't think it's clear because I'm not clear on that if it's real. I don't think they've ever done that kind of exact, or I haven't seen any clinical trial that exactly looks at the difference that way. They just have these epidemiological statistics showing the advantage of Provenge and Provenge when it's a low burden, but I don't think they've ever dug in deep enough to divide all that. And I guess you can be castrate resistant while still being oligometastatic, or just having a localized metastasis, and therefore the Provenge doesn't have to succeed in closing off hundreds of thousands of potential sites throughout the body. And what that means as related to what a cancer burden is. That was the only thing that runs through my mind.
I don't know. Rick, do you have any thoughts on this? Or Len?
Well, I've actually asked Len if he could take a quick look at the two links.
I was about to answer in the chat room.
Okay, so we'll come to it afterwards. But the only thing I can tell you is this, Larry. If I've heard Larry, I'm getting my L's wrong. Here's what I can tell you, Larry. Whenever I've spoken to Larry Fong about this, he always says the same thing. You've got to have the longest landing strip possible. And when you push him on, what do you mean by landing strip? It's not really clear, but basically I get from it is that the tumor burden has to be as low as it can possibly be. And the lower the tumor burden, the better off you are. Now, if you say, well, look, you got a lot of spots, but the Lupron seems to have gotten rid of quite a few of those, but they could come back. I think that means the tumor burden is lower, but what do I know? I mean, you have to ask some of these experts what they think it means by having a lower tumor burden. I mean, Herb, do you think that you have a lower tumor burden now than you did 2 years ago when you lit up like a Christmas tree?
I think I do. But, the scans don't show. I mean, again, the scans, I don't have a comparative scan, so it's hard to say. But certainly the PSA is lower, but what does that mean? I don't know.
It means that there are fewer cells expressing PSA,
Yes.
right?
At the moment.
So are they dormant? Are they dead? I don't know. I mean, it's all about how do you measure the tumor burden, Larry Fish?
Yeah. This idea of it's a more complex, not a more complex, a deeper thought is you can run around looking at treatments that seem to provide a greater successes and have more options. But you don't actually know about your individual case if that's true because they haven't really, done the deep dive into the data and the studies. They're limited. Studies are limited. They come out with something, it looks good, you try it after a while. Provenge seems to have had a long run, and I'm sort of on the verge of thinking about it. But I'm still curious about if that's going to work in cases like mine rather than in just cases where it's
Larry,
pretty
the problem, Larry, we don't have the data. There's no way to measure it, right?
Yeah. So it's a little bit of a shot. It's a little bit of a shot in the dark to some extent, with seemingly good results. But exactly how many other possible shots in the dark are there?
Well, I don't know.
But here's how I see the Provenge, Larry. It's like chicken soup. It can't hurt you, and it may help you. And if you are eligible for it, and you've been castrate resistant, and you're managing your disease, I would get it. The fact that Memorial Sloan Kettering doesn't give it, it's their issue. And
I'm not defending Memorial Sloan. Don't worry.
I mean,
this is my thinking.
I don't think that they're serving their their patients as well as they could when they don't offer Provenge, and it's been an issue for years with Memorial Sloan Kettering and Provenge. They don't do it, but you have to find somebody who does do it because I mean when we heard the presentation from the representative of Provenge quoting a bunch of studies, it was impressive. It impressed her.
Larry, I mean, I think the data are pretty clear for the group of study participants. It does significantly extend life, and the more extends it, the lower your PSA. They don't talk about tumor burden. They just simply talk about PSA at the time of getting Provenge. Okay? My presumption is that after lots of other treatment, because you had to have had treatment to make when you were hormone sensitive. So, why am I getting it? Because and I do look at, and I also think it's an immune therapy, and I have a feeling if we talked about the abscopal effect, I have a feeling if I get future radiation that it may be some synergy there.
Right.
Okay, thank you, guys.
Can we just give Tommy and Mike and Tommy a very quick verbal on those two studies?
Thanks, everybody. Thanks for letting me.
So, Mike and Tommy, you found those papers on NCBI, which is PubMed.
Oh, okay.
The role of NIH at PubMed is simply to maintain the database and make it public. So when you click on the links to the papers and you look at where they're from, one was from China and the other was from a group in Atlanta, and they both talk about quercetin, which has been an antioxidant. It's an antioxidant compound which has been studied for a number of years. And yes, it may have some effects in cultured cells and in the lab, but it's not ready. It's not anywhere near clinical relevance.
Thanks, Herb.
Len, did you want to add anything?
No, I agree with Herb. It's only been studied in vitro in prostate cancer cell lines, not in the clinic. So,
Okay. I think I'm trying to learn how to do research.
There's a lot of it in food. It is a natural product.
Yes, I read that. Well, I read the articles to the extent that I could because they're really a lot of scientific stuff. But I want to, when I saw that and I saw 2 articles, I just thought maybe that I ought to look at them. And thanks. I didn't mean to take so much of your time.
No. Yeah. That's why we have the groups, and it's great that you. That's why we're here. It's great that you did that, but this is the best way to do it. Because you could have sent them to me, I wouldn't have even known what I was looking at, and I don't have the time to wade through them. Len and Herb can look at these in a few seconds, and they can tell you what's relevant, and that's exactly why we say to people, we ask you if you've got a question, and you should say yes, and you put it in. Could you tell me, is this study relevant? Perfect. I did want to mention one thing to you, that because you mentioned you saw this on the Facebook Prostate Cancer Caregivers group. You know that we have a caregivers group. I know.
I thought this was the one I went to.
We have a caregivers group for caregiving for it's what we call a pan cancer group. It's open to caregivers of stage 3 and stage 4 cancer, for any type of cancer, although there's a lot of we get mostly prostate cancer people.
Right?
And that group meets on the first and third Tuesday of every month. So it's going to meet tomorrow night.
It would be the same thing we're doing now, but for caregivers?
That's right.
Oh, I don't know how I missed that.
Okay.
The Facebook group. It's from AnCan?
Say that again?
No, Mike's answered it for me. I'm going to investigate them. Very, very grateful.
So the first thing I'm going to do right now for you is I'm going to put the link to the group in the chat window for you. And there's one thing that I've got to advise you about on this group, and hold on a sec.
Rick, you're dropping out.
Cancer caregivers, copy link. So the links.
There it is.
Everyone. That link is now so you click on that link. I will make sure after the meeting that you're signed up for it. You should be getting, if you are signed up for it, you should be getting the reminders. Let's see if you're signed up for it. Because sometimes people sign up for these groups and they don't.
Rick, you're dropping out.
Yeah. Rick, I will go and sign up. I don't think I've signed up because I've gotten no emails from anyone.
Well, but tomorrow night, just go to the Cancer Caregivers, AnCan.org, and you'll be there.
I will. Thank you.
Okay. Anybody else? Comments, questions?
Just to clarify about Provenge, it is, to my understanding, and continues to be the only approved immunotherapy treatment for prostate cancer. Keytruda has been looked at. I am currently in a trial using Keytruda as an immunotherapy, but it's not ready for prime time for prostate cancer patients.
I think that's right, Carl, and it's been around for quite a while now. So if it were a dud, we should have heard about it.
And at the time I had it done in January, February 2019, it was quite expensive. It was, thank goodness my insurance covered it, but I saw what was charged the insurance company, and it was several $100,000. So
now it's, according to what I read, it's like $31K per cycle.
Wow, great.
Of course, that means if you think about it, if it extends life by a year, average median a year, so you're paying roughly about $8,000 a month. So that's what life is worth, guys. It's worth more than all of that to us. So
a lot of those second-line anti-androgens cost about that much.
Right, exactly. At the beginning, before Abby was generic, it was really expensive.
I think Darrow was about $10,000 a month.
So Okay, I would like to thank everybody for their participation tonight, and see you all next week, hopefully. Next Tuesday at 6 o'clock Eastern.
Yeah, I'm back just for sorry. I've been having hell of a time with my internet connection tonight. Tommy, the first group does not discuss bereavement and grief. The second group in the month does. So I just wanted to give you that heads up.
Okay, the first group in the month is what I probably want to be in, right?
Right. I mean, it's open. Both groups are open to you. You can come to any one, but you just need to know that in that second group, we may discuss people that have lost their partners already or grieving because they're pretty sick, but we may not. But we want to give you a heads up to let you know that it happens. In the first meeting of the month, we do not. It's off the charts. But you can come in and decide to leave as well. That's okay too. The moderators are great. They're really nice. They're really great ladies.
Thank you, Rick.
Okay, any other things? Okay, I'm going to stop recording now. Yes.
Just a quick note to Mike and Tommy. What you were talking about before, it's an over-the-counter supplement. Those things are not regulated by the FDA. It's kind of a crapshoot if what they say is in the pill really is in the pill. And there's lots of evidence that many of these supplements don't contain either the amount of ingredient that they claim or not at all. So just be careful when you're dealing with supplements.
No, I'm just starting to learn how to research, and I didn't notice that it wasn't the NIH. It sounds like this could be something like the ivermectin, lots of information that isn't correct.
Yes.
Hey, I appreciate everything. Thanks.
Okay.
Is her husband there? Or she's. Yes.
I will stop the recording now. And we will say goodnight for tonight.
Great job tonight, Herb.
Good night, everybody. Thank you, Herb.